do thank you for coming out. This is a real pleasure, a real honor for me. I may have mentioned 12 times last time I was here that I got my start as a high school teacher. So I really like, this is just exciting for me to hopefully teach, inform, share, and learn from a body of colleagues such as yourselves. For some of you, this is going to be a bit of a history lesson. So I want you to remember many, many years ago, before there was an internet, before there was Kudrow doing web therapy, and before there was Skype, there was a technique called the two-way mirror. And the two-way mirror was often accompanied by a telephone. And that was referred to as live supervision. In the 1960s, Montalvo, Mnuchin, both in Philadelphia, and Jay Haley out in Palo Alto, began to look at something they called strategic and structural family therapy. And it was piloted in Philadelphia Child Guidance, 1965, 66, 67. In the late 1980s and early 1990s, my training was at the Philadelphia Child Guidance Clinic. And these guys, although they were kind of retired, they were all emeriti, and they were pretty much, as our family therapy professor said, next to Freud, they are our gods. And they would come in, and we would have guest lectures with these guys, and they were brilliant. They were it. Well, one of the things that they used to do is you would go into a setting, and it looked like something from The Honeymooners or I Love Lucy, and it was a set, and it looked like a living room, and you, as an intern or a resident, you would be doing your family therapy. But of course, there was a telephone on the table. And again, you're just this kid, and you're young, and you've got this family. Invariably, what they were trying to do was work with urban families. So you'd have this little urban family, and the kids would be going all over the place, and the mother would be yelling, and the father would be snoring, and you would be trying to do therapy. And all of a sudden, the phone would ring. And it was just the worst, because your heart would stop, because you knew it was one of them behind the two-way mirror saying to you, invariably, "Why did you say that?" Well, as you can imagine, after a couple of times, it goes through the class, all of us students, we're starting to whine about that, as students whine, as you guys can recall from either yourselves or your classmates. So we start whining about it. And that's not fair. How can you ask them? We're in the middle of a therapy session, blah, blah, blah. So one of our mentors, George Spivak, just a brilliant psychodynamic cognitive psychologist, taught us about this whole idea of always know why, as a therapist, why you are doing what you're doing. Always be able to defend yourself. And he had a whole class on this, and it was, I don't know if it was like existential something or other. But basically what it was a deconstruction of the therapeutic experience. And I recently had the opportunity to listen to a case presentation where it was a challenging case. It was actually, this is what spurred the topic. It was a dual diagnosed with a borderline personality disorder. And, one of my colleagues here, Dr. Markham, and I were listening, and finally we asked this resident, well, what are you doing with this guy? This is a nightmare situation, really challenging. And the kid on the other end of the phone, he was almost crying, just said, "I'm just trying to keep them together." And I thought, okay, well, that's like step one. You're right, we don't want them to decompensate. But I thought, the resident needed a roadmap. So what I want to do today, and for some of you, this will be, just hopefully a refresher. Maybe you can use it in your own supervision. But it's kind of what I do when I do teach or work with residents or students, is go through a whole interaction, introspective experience. What I'm hoping that we'll do today is look at how we conceptualize a case. At the end of it, I'm not going to tell you anything, hopefully, that you don't already know. But hopefully, what you'll get out of this is an opportunity to look at your own decision-making process, your own presence in the therapeutic relationship. I'll probably use words that sound a little psychodynamic. I'm trained in that way. I think I work from a cognitive perspective as well, but I do conceptualize cases through a psychodynamic lens. I'm hoping you'll see the APA verbs: apply, develop, utilize, apply. Those are some of the verbs that APA likes. So I'm hoping that as therapists, you'll apply your knowledge of hypothesis testing, develop a personal treatment approach, and utilize, and these are the concomitants of a hypothesis, right? Research, data, personal experience, okay, that's the intuition often that we come to this with, expertise, and then the client's needs, so that we can apply those elements to clients who have a very complex co-occurring disorder. By the way, this presentation will be available through email. I'll give you an email link, and we can send it to you rather than kill trees. So this is what I'm hoping that we'll look at is look at some of the theoretical models of both borderline personality disorder as well as addictive behavior. Eventually, I'm hoping you'll see the logic. I will eventually hopefully get to dialectical behavioral therapy, because I think you'll see that some of the elements here and here are found in DBT. So what we want to look at is, and I think this is important, especially if you're doing supervision, for us to teach our supervisees what's their working hypothesis when they're facing a client with an AOD. We'll use the abbreviations AOD or BPD. And it's the question, why did you say that or do that in therapy? So the thing that we have to be really careful about is we expect, if you've ever sat in on an admissions process to a graduate school program, one of the things that we expect is intuition. That's kind of the very basic. We expect all of our clinicians to have some level of intuition and empathy. It's hard to teach empathy, so we expect that coming in the front door, we have an empathic group of students in front of us. However, we've got to be careful when we have a supervisee who says, well, it just felt good. It felt like the right thing to do. Well, okay, maybe that's how you buy a birthday card or whatever. But as clinicians, we've got to rely on a body of research. We've got to be able to say that we did this because, well, there's research out there that says this is an effective intervention. Our hypothesis has to link to the client's capacity, right? Clients come to us with a certain functional level. So we've got to meld these two together. Diagnostic. One of the things that at Sovereign that we're in the process of doing is implementing a standardized diagnostic protocol. We were going to use the SCID and a couple of other instruments, and then from there branch off into 10 diagnoses based on what the baseline data gives to us. Because really what I'm finding is there is so much that our clinicians need to know, particularly on the old Axis II. All right, the behavioral manifestations, the Axis I, are replete. They're quite, out there, but we really need to touch a little bit more in depth with the Axis II information. Certainly, we never want to downplay the wealth of experience that we've accumulated via supervision, via lots of hours of therapy, and of course, the hypothesis is going to be informed by the countertransference and the transference. Okay, again, that's coming from my bias as a psychodynamically trained clinician. I want you to think when you're writing a treatment plan. All right, just think about this for a second. What do we always now? We've been trained by managed care and by state regulations to be positive, right? So it's all strengths-based. Well, all right, be that as it may, it's all strengths-based. Well, so we're trying to improve quality of life, learn more effective skills, improve relationships, so we got to improve, learn more, improve, reduce, okay, anything else. So look at this. So what we're saying basically is the patient comes into us from our perspective. The patient may not agree, but from our perspective, change needs to occur. All all right? Oftentimes we know our patients don't agree with that. They don't know why they're, particularly in a residential setting, they don't know why they're here. Somebody carted them off. But somehow, based on our own treatment plan goals, we're saying change needs to occur. There's got to be something different here, right? And then you can see, I just, if you get a copy of the presentation, how do people handle change? Those of us who are ADHD love change. We live in change. I mean, I love change. Status quo it's one of the reasons why I got here to Sovereign, is it's such a non-status quo company. There's always opportunity for something new to happen. Other people, it's not going to be fine. Change is never fine. They say it is, but it's not. And there are some people who prefer, predictability. And if you're working with a client who has dementia or brain injury, an older client, predictability is your friend. Consistency is your friend. Same thing with little kids sometimes. But we're implying in the therapeutic process, change needs to occur. All right? Now, you have to answer the question, do people change? And there's lots and lots of research. Yes, they change. No, they don't change. You can change this. You can't change that. But it doesn't matter what the research in that area, is telling us. It's what do you believe? You are the change agent. You're the therapist. How do you conceptualize change? Do you believe it can occur? Hopefully, most of us in this room do believe in change in some degree, maybe evolution, maybe assimilation, accommodation, but hopefully we believe that the status quo can improve, particularly for a client who is suffering or struggling. So when you're in the therapeutic, office, I don't know if you've ever sat there and the client asks you a question back and you're like, oh God, how am I going to answer this one? Because sometimes they ask really, challenging questions. Why should I do that? If you're with a drug and alcohol, I'm just stunned with drug and alcohol clients who've mastered the art of being a survivor. And they come in and they're either indigent or close to indigent, and we're telling them there's another life out there, and they got nothing. They got their backpack, and that's it. What other life is there? They can't see that. We see it, we present it from our perspective. But from their perspective, change is not going to be their friend. They've learned how to live in an alley. They've learned how to beg for a couple of bucks, all right? So sometimes, what I want you to think about is when we deconstruct the therapy, we're saying, why? Why did I ask that question? And I'm sure there are times when you're in therapy and you say, oh God, you ask the question and then the client takes you that way. And you're like, oh damn, I wanted to go that way. It was like either the wrong question or maybe it wasn't direct enough or you were trying to hedge your bet a little bit. So why did you assign a particular homework task? Ask the question, why did you remain silent? What was the purpose of not answering, of letting that silence kind of percolate? Why did you do that? Why did you respond to your client in a certain way? Again, it's a deconstruction of the therapy. And I think if you're supervising, this is a good exercise to lead your supervisees. If you're not supervising, it's a good exercise just to do in your own introspection. Why am I doing that when I'm faced with this kind of a situation? So again, you go to change now, not only change, but changing a maladaptive behavior. Okay, because it's from our perspective, we're saying to the fellow, and this is where DBT comes in, we're saying to the client, are you looking at what your decisions are doing to you? Now, are you seeing where they're leading you? From our perspective, that needs to change. However, they can turn around and say, you know what though, I'm alive. So maybe it ain't so bad. Right? So again, it's going back to what do you think about the change experience? Can a tiger change its stripes? And I thought this was interesting because these are all kind of little stripes. I don't know why I put it up there. I needed a color slide or something. So there you go. So now we get into this whole thing, and this is psychology has struggled with this forever. You guys remember this from social psychology classes, from personality theory classes. Do people change? Does personality change? People will say it's crystallized. People will say it's fluid. Is it trait? Is it state? And I think the one thing, and this is where the transference and countertransference can be your friend, I think it is a good idea to think about how, as a therapist, when you're out of the therapy role, how did you manage a change? Look at the changes in your life, single state to married state, moving from East Coast to West Coast or West Coast to East Coast, behavior identity. Certainly, if we're dealing with folks with gender identity disorder or transgendered issues, that's a huge change. But think about your own experience. How did you manage change? What worked for you? What was your friend in that? What was a challenge that you experienced? Because it's likely that will help you in the therapeutic process manage the other person's either reluctance or fear of or enthusiasm about change. So I think that this, again, we're going back to the theme that I talked about earlier about introspection. Some of this presentation today is designed to have you start to think about your own presence in the therapy.